So welcome back once again to another session of MIT. And in this, we will be talking about the various study designs. And I welcome Dr. Kiran Chaudhary. She is head of the Department of Transfusion Medicine, and she has a vast experience in as a researcher and as a biostatistician. And I believe that she's going to do a full justice to the topic, and we are going to enjoy her talk. So along with her, we have few participants. Dr. Nitin Chaudhary, he is an assistant professor in the Department of Anesthesia, and Dr. Priyanka, from assistant professor from Department of Anesthesia. We also have Dr. Nitin Agarwal, who has been a constant support to MIT. I welcome all of you, and ma'am, I hand over to you to start with your talk, please.
Thank you, Ajal, for your introduction. And I also thank the Med Division to provide this opportunity to me to give this presentation on study designs. Now, before I begin, I would like to acknowledge two people in my life. One is Dr. Edward L. Murphy and Dr. Willie McFarland, from whom I learned research methods. And this created a lot of interest in me. And then I pursued further and I learned a lot about research methods over time. And I'm also using the slides which they had provided when I was their student. So you people must be ready with the research question. And the research question has the characteristics of finer. So what are these characteristics? F stands for feasible, I for interesting, N for novel, E for ethical, and R for relevant. Now, what I suggest that before I start study designs, if you have these finer characteristics in your research question, you still should be open to modify it. Because if it is not ethical, certainly it is not going to be a very good thing to do as a researcher. So you must be mentally prepared to refine it and then choose your study design. So basically, I'm telling you about the hierarchy of the study types. We have two types of studies. One is a descriptive study and the other is an analytic study. Within the analytic study, we have two groups, observational studies, experimental studies. Now, I will be now dealing with each of these designs one by one. So to begin with the descriptive studies, I will be telling you about case reports and case series. So at the end of this slide, below the slide, you see a white line, and this white arrow, it goes towards the right of your screen. And what does this indicate? As we proceed through the study designs, what you will see is the strength of evidence for causality between the risk factor and the outcome increases as we move towards the right of your screen. So the randomized controlled trial provides the highest level of causality between the risk factor or the exposure and the outcome. So what is a case report? In your clinic or practice, you see an unusual case and you feel that you have never seen such a case before. So this one new case also can be published and reported, and this becomes a case report. Next is case series. So several such new cases you are seeing in your practice, in your clinics, and they could be linked to each other. Now, reporting case series helps us to generate a new hypothesis. But the disadvantage is that there is no comparison or control group in this. So here, if I diagrammatically show you how a case series looks like, the perpendicular white line shows where the researcher is standing. The researcher is placed in time, and he sees a few cases in his clinic over a short period of time in the previous weeks or months. And then he decides that he should collect data on it and document it. So this is a very good example where in Los Angeles, 26 homosexual men who were in their 30s came to the clinic with Kaposi sarcoma. This was the year 1981. And you will be surprised to know that this was the discovery, this led to the discovery of AIDS. Now, what are the advantages and disadvantages of case series? You are the first one to describe rare and new disease, and it helps to generate a hypothesis on the causes. And of course, it is low cost study. The disadvantage is that there is weak evidence of causation, and there is a no control group, as I had told you previously. Now I move on to the observational studies. Now, why are they called observational studies? Because the researcher is only observing and not intervening actively. So the researcher has no control over the exposure of the subjects, like as you have in randomized controlled trials. So when a randomized controlled trial is planned and you see that it would not be an ethical or a feasible study, then you always would want to do something of an observational type of a study. So what we do is that we record the exposure and outcome only by observation, not by actively intervening. And there are two terms which people should be familiar with. One is retrospective and the other is prospective. So when you look backwards in time, then it is a retrospective study. When you look forwards in time, it is a prospective study. But it provides a weaker proof for causality when compared to a randomized controlled trial. But usually it is less expensive. And this is the most common design. The observational studies are the most commonly designs, published studies. And yes, as I told you earlier, it is publishable also. So we have three types of observational studies. Cross-sectional studies, the exposure and disease are examined at one point of time. In cohort studies, one or more groups which are defined by exposure. I have highlighted this. They are defined by exposure. They are followed over time for the disease to develop or the outcome to happen. In case control studies, we have two or more groups I have highlighted defined by disease. And you go back in time retrospectively and you find out about the exposure. So we will start with cross-sectional studies. This helps to measure the prevalence of disease or the risk factors in a population at one point in time. So you go to the population, you enroll subjects, you can conduct screening tests, you can have interviews with them for a short period of time. Now, this is very important that it does not become prospective. If it takes a bit long for you to enroll all the subjects and collect the data, it still remains a cross-sectional study. And what does a cross-sectional study do? It measures the association between having the risk factor and having the disease. Now, this is a diagrammatic representation where you see the population in a circle. In the population, there are diseased people, there are non-diseased people. You want to measure the risk factor or exposure. So you as a researcher go and you take a snapshot. So cross-sectional studies are called snapshot studies or prevalence studies. Now, this explains it very well. The researcher is standing at the white perpendicular line and he goes and he collects data, and what does he find? He finds this combination. X is disease, so he has participants with disease, with the risk factor, with disease, without the risk factor, and sometimes there is no disease and no risk factor. So you come back with this data, and this is an ideal cross-sectional study. So what are the advantages? It is a representative study for the risk factors or for the diseases in a population, and it provides you with prevalence data. You can study multiple diseases, you can study multiple risk factors, and you have more control over the measurements than a case control study, which I'll be dealing with later, where you have to depend on the patient's memory, or you have to depend upon the records. Here you are actually yourself taking the data, measuring the data. So it is not feasible for rare diseases. Why? Because supposing you go into a locality and you're looking for patients of lung cancer, you may not even find one, or you may just find one or two. So it's not good for rare diseases, and it gives us a weak evidence for causation because the cause has not come before the effect. I can explain this with another example where say a hormone X is found to be associated with acne. You go into the population, you measure the levels of hormone X, and you see your participants are patients of acne. And then here you cannot prove whether the hormone levels, high hormone levels are causing acne, or acne has caused high hormone levels. So therefore here you cannot establish the cause whether the cause has happened before the effect or the disease. Now, this is an example of a cross-sectional study, the health evaluation of the young man or the Hey Man study. Door-to-door survey of men in randomly sampled blocks in poor neighborhoods of California was conducted, and blood was tested for so many diseases: HIV, HBV, HCV, syphilis. Along with it, urine was tested for gonorrhea, chlamydia, and they had also applied this questionnaire on risk behavior. So we have done so many things in one cross-sectional study. Now, you can also do serial cross-sectional studies. This is for studying the trends. So when you do repeated cross-sectional studies in the same population, and it can be done annually, it can be done monthly, depending upon the objective of your study, but they may not be the same individuals. You can do it serially in the same population. Measure the trends in disease or risk factors over time. So what does this do? This shows us the trend of disease. Is it increasing? Is it decreasing over a period of time? And you also know the sequence of events by doing serial cross-sectional studies. This is very common in surveillance and blood banking reports. So this example shows us that we have studied this population. There is two groups. One is of anonymous testers and the other is of the STI clinic attenders in 96, 97, 98 and 99. And what do we see? That the incidence rates of HIV among these two is rising over this period, showing us the trends. Now, what are case control studies? Case control studies are studies where you start with the disease. So the diseased participants are your cases, and you as a researcher choose your controls, and the controls are those who are without the disease. And then you go back in time and you compare the prevalence of risk factor in the cases versus the controls. Now the hallmark is the disease outcome status at the time you select your study subjects and before you know the exposure status. So you have to always remember that you have to start with the disease or the outcome and go back and see the exposure. So this is a case control study represented diagrammatically. You have one group of cases, you have the other group of controls. You are going backwards in time retrospectively to measure the risk factor or exposure in both the groups. The researcher is standing at the white longitudinal line and he has two groups. X is those who are diseased and O is those who are not diseased. He goes back in time and then he looks for the exposure or the risk factors. Now, the problem with this is that you have to collect data from records or from patients' recall, and therefore you have a recall bias. Now, this is an example of a case control study where there were two groups of partners or couples, in which in one group, HIV transmission had occurred from one partner to the other. And in the other group, only one partner was HIV positive and the other was negative. So what we thought was the risk factor here was whether the partner or the HIV positive patient was on heart treatment or not. And then what was found finally is that those on heart treatment did not transmit the virus to the partners. Now, what are the advantages and disadvantages of case control studies? So you do this study especially when you have to characterize rare diseases. It involves lower cost. It can also be used for outbreak studies. The disadvantages are bias in the choice of controls. Many times you don't find controls. You may use relatives at controls, which is not a very good thing to do. And then there are challenges in matching. So since the researcher has to select the controls, now he has to match with a lot of caution. Generally, you match for age and sex, but the researcher should sit down and actually note down all other factors or variables that could confound the study and try to match them here. There is bias in accuracy of data, recall bias. As I told you earlier, we all know that even if we are asked to document our history of taking coffee or tea in the past 1 week per day, we will not be able to do it with accuracy. And therefore, there is weak evidence of causation. Then we move on to the cohort studies. So prospective cohort studies are longitudinal studies followed prospectively over time. You recruit subjects without disease at the baseline. So this is a very, very important thing which we all have to understand. And then you measure the risk factors or exposures at the baseline. You do not control for exposures, but you know them, and you deliberately choose your subjects by exposure. And why this is so? Because this is an observational study. The researcher is only observing, So he knows about that, and he makes his two cohorts or groups depending upon whether the risk factor was present or not. But he does nothing and he just observes. And he follows up the subjects over time, retests for the disease, and then he associates the risk factors at the baseline with the later acquisition of disease. This is a diagrammatic representation. Prospective and retrospective cohorts work on the same principle. So you start from the risk factors and you move on to the outcomes. Here you have two groups. One is exposed to the risk factor, one is not exposed. You followed up over time, and then finally you measured for the disease or the outcomes. Now here the researcher is at the first longitudinal line. He is recruiting his participants based on the risk factors and not on the disease. So it's very clearly shown here, 0 depicts disease. So none of them have the disease, and they are being selected on the basis of whether they have the risk factor or they do not have the risk factor. They are all followed up over time prospectively, and then at the end the disease status or the outcome status is recorded. So what are the advantages? This gives us a high level of evidence for causality, because here we can show that the cause has come before effect, and it is a direct measure of the disease incidence. So for incidence studies, we use the cohort study design. The disadvantages are it is expensive, time consuming, a bit complicated, and not feasible for rare disease, because at the end of the day, you may not find any outcome at all if it is that rare. And here, the most important bias is bias in loss to follow-up. Bias in participation also. Supposing you are giving one group yoga classes for half an hour and studying what happens to the hypertension, the other group is not having yoga classes. Now what happens is some of them may not be doing yoga for that half an hour or daily or whatever your protocol says. So therefore, there is a bias in participation also. Now this is an example of two cohorts. The blue one shows that they have high risk behavior. So behavior change was taught to this group, or they were given behavior change education, and the other group had been given vaccine. Now what we see is at the same time they were enrolled, same place, same population, same eligibility, same institution, but the exposures were different, and you are just observing. And after a period of time, what do you see? That the HIV incidence among those who were given behavior change education was less than those who were given vaccines. Now, what is a retrospective cohort study? You have to use existing records and specimens saved from another cohort study or another ongoing follow-up of patients. So here we study the existing record. So we have almost no control over the data collection. We have to depend on whatever data is available in the records. These are longitudinal studies, but all events have occurred in the past. So be very careful. The exposure has occurred in the past, and the outcome has also occurred in the past when you start doing when the researcher starts the research. The researcher is at this longitudinal line, white line, and he knows that the outcome has occurred in a few of them. He goes back in time. He looks up the records for the risk factors, for those who are exposed and for those who are not exposed. And he comes back again to check whether Those with risk factors have the disease or not. Those without risk factors have the disease or not. So you can see that this arrow is pointed both ways. So you go retrospectively into the past, you check the historical records, but you are actually starting the study from the exposure to the outcome only. And hence it is a cohort study which is done retrospectively with historical records. So advantages are it is low cost, it can be done very fast, it is suitable for repeat blood donor panels, you have less control over the subjects or the participants, and you have less control over the measures because you have to depend upon what has been recorded earlier. And the analysis is also slightly complex. Now, if you are lucky, you will be able to do a very good retrospective cohort studies if you have all the documents with you or all the blood samples preserved in the way you wanted it to be. So this is an example where you are studying two groups of gay men who inject drugs, and the other is heterosexual men who inject drugs, and you think that there is going to be a difference in this. So you go back in time, you see the records or you have the blood samples preserved, and you look for incidence among these two groups. And then what do you find? That gay men who inject drugs, the incidence is higher than heterosexual men who inject drugs. So now, choice of observational study design. So I start from the lowest to the highest. So I start with case series. When you have discovered something new and you want to publish it first and fast, then you choose case series. When the disease is rare, your most easy choice would be case control studies. When you want the prevalence of many diseases and many risk factors in one population, you do a cross-sectional study or survey. When you are lucky, you have the right population and you have access to good records, you do a retrospective cohort. When you are rich and you have the highest level of scientific evidence, you want the highest level of evidence except RCT, then you choose a prospective cohort study. After this, I move on to the analytic study. So analytic studies attempt to establish a causal link between predictor or the risk factor and an outcome of the disease. Before this, what were we doing? For all the three types of studies, we were just looking at associations. Here we want to establish a causal link. Now you are doing an analytic study. If in your research question you have these words, greater than, less than, causes, leads to, compared with, more likely than, associated with, related to, similar to, or correlated, which clearly tells you that there are at least two groups and you are trying to see which group is better than the other. So now what distinguishes the observational study from the analytical or experimental study? Your ability to control for confounding. It is very, very important. And what is a confounder? So now this is a confounder, it is a variable, and you have a predictor or a risk factor and an outcome or a disease. So this confounder is associated with both the predictor and the outcome. Here we can take the example of smoking as a confounder, coffee drinking and pancreatic cancer as the outcome and the predictor. Predictor is coffee drinking, pancreatic cancer is the outcome. So what the hypothesis is, or what some studies showed, that coffee drinking is associated with pancreatic cancer, whereas this was not true. It was actually the confounder smoking, due to which this result was coming, and it was a spurious result. So since those who smoke also drink more coffee, it was thought that coffee drinking caused pancreatic cancer. So hence smoking here is a confounder. So in randomized controlled trials or analytical or experimental studies, the investigator controls the predictor variable or the exposure or the intervention, and this is the main focus of the whole study, that the researcher is being able to control the exposure. Now the major advantage over observational study is the ability to demonstrate causality. As I told you earlier, we were just looking at associations and not a causal relationship. Randomization controls for the unmeasured confounding. So now some confounding variables, at the start of the study, you should sit down and you should document all, and you should know what all are confounding. But there are some colors which you cannot measure. So by randomization, as in the name suggests, randomized control trial, you are actually controlling for this confounding. And this study design is only good for mature research questions. So what do? You have a study population at the baseline, and then you randomize them into two groups. In one group, you give the placebo. In the other group, you give the intervention. You follow them over a period of time, and then you measure for the disease or outcome. So there are two guiding principles. You have to ask an important question. So if you can ask an important question, then I think you should go, and you get a reliable answer, then you should go in for randomized controlled trial design. So is there really uncertainty about the best treatment or procedure? Will the trial results change the clinical practice? If you are not able to answer these two, then there will be a lot of ethical issues, and this design will not be the best design. And similarly, you will have to give a reliable answer and adequate sample size. So is it feasible to have that much of population, that much sample size? Or can you see to it that the protocol is adhered to strictly? So you have to maximize the follow-up and adherence to protocol. If you cannot do that also, then this is not the best design for you. Now I will quickly go through the steps in a randomized controlled trial. So first you select the participants, and it should be for a high-risk disease, say for HIV patients. So you should have that in the HIV patients or that risk factor in your population. And your participants are likely to benefit and not be harmed, and they are likely to adhere to the protocol. Then you measure the baseline variables, you randomize, you eliminate the baseline confounding by randomization. So you use a random number table, and there are different types: simple, stratified, block randomization, etc. And you randomize the patients. So how does it help to eliminate the confounding? Now, the unknown confounders by randomization are equally distributed in both the arms, in your study arm and in the control arm. Then blinding is also very important. It is as important as randomization because it eliminates co-intervention. Now, if the patient does not know that he's in the intervention arm, and if the researcher does not know that he's in the intervention arm, so it is less likely that they will do things, intervene in other ways so that the results go in their favor. So sometimes, generally driven by commercial interests, some people, they try to intervene in such ways and the results are biased. So biased outcome ascertainments and biased measurement of outcome. So the person who is measuring the outcome also should be blinded, and person who is the participant is blinded, the researcher is blinded, and the person who does the data analysis also can be blinded. So you can blind at different levels depending upon the objectives of your study. Then you follow the subjects for adherence to protocol and for loss to follow-up. And then you have to measure the outcomes. In addition to the clinically important measures, you have to also record the adverse events in a randomized controlled trial. So now, just because a predictor variable is statistically associated with an outcome, does it mean that it causes the outcome? There are four possibilities. Either it is causal, either the results have come out favoring you by chance, or some bias or error has been introduced, or there could be confounding. So many wrong public health or clinical decisions can be made if the relationship is not causal. So proof of causality is difficult, especially in observational studies. With this, I like to summarize in 2 points that no study is perfect. Each has its potential biases and limitations. And no study design is right or wrong for a research question. Each has its appropriate place. Thank you.
Thank you so much, ma'am. You can stop the sharing of the slides. And it was a wonderful lecture, ma'am. It's so simple. I am 100% sure that all the PGs will be able to understand and they will be able to do further justice in their future research, uh, whatever they plan for. So now I would ask our participants, Dr. Nitin and Dr. Priyanka, if they have any questions to ask.
Hello.
Yeah,
Can you
Dr.
hear me, ma'am?
Yes,
Yes.
I can hear you.
Yeah, a wonderful presentation, ma'am. Very simple and yet very informative. Thank you so much. I'm sure it's going to benefit all the people whoever will go through this presentation. Ma'am, I have one question regarding your presentation. Can you just throw some light on the difference between a confounder and an effect modifier?
Yes. So I'll try to explain that. You see, as I told you, the confounder sometimes can be accounted for, sometimes you do not know what it is. And it is actually associated with both the exposure and outcome. Okay. And then they are bound to give us spurious results. So before we start a research, we should know what a confounder is and we should document it and we should have a list ready so that at the time of analysis, we have the data for the confounders and it can be treated differently. Now, actually, if I use a layman's language, it's of nuisance value, and we don't want it as researchers. You know, it's going to affect your study. It may affect it in a positive way. It may affect it in a negative way, but the researcher does not want a confounder there. You know, so it is actually creating a lot of noise, and we do not want it there. And there are several methods, especially when you're designing the study, and if you think smoking is a confounder, you may not have people who smoke, but then finally the generalizability of the result becomes very limited. So your results will be valid only for those who smoke or who do not smoke if you have not taken one of them into your study. So actually the best thing is to document them, to collect data on them, and at the level of analysis, either stratify or you can do a regression analysis and you can find out whether that confounder is actually harming your study or not. Now, as far as effect modifier goes, effect modifier is associated with the outcome. And effect modifier actually acts as a catalyst and it enhances your study in a way. So what happens is, supposing if I take an example of use of OCD, oral contraceptive drugs, and I say OCD causes breast cancer. But if the female or if that participant is genetically prone to develop breast cancer, the use of OCD actually acts as a catalyst and it increases the risk of breast cancer. So these are the differences between effect modification and confounding. I
Thank
hope
you,
that
ma'am.
clears it.
Yeah, thank you so much, ma'am.
Okay. Any other questions?
Dr. Priyanka, you want to ask something? Please unmute yourself, Dr. Priyanka.
Good evening, ma'am.
Good evening.
Can you please explain what is the difference between a case control design and a retrospective cohort study, as both are retrospective?
Yes. So a case control study, as I said, the mantra is that you begin with the disease. Okay. Whereas in a retrospective study, you begin with the exposure. And you remember I showed you that slide where I showed you that the arrow is pointed both ways. So you actually start your study, you start your study after the outcome has occurred, but you go back in time and you start your study from a point in time where you as a researcher make two groups of those exposed and those not exposed. You move forward in time after that till you reach the outcome. So in a way, you go back in time to get the historical records, but actually you are following them over prospectively only, even in a retrospective study. Whereas in a case control study, you start with the cases. The researcher will actually then choose the controls. Generally, it is 1 to 1, or it can be up to 1 to 4. And he moves backward in time and he collects the data. You see, the data may be there, but he will then collect samples, or he will apply some questionnaires, or he will look for other history, and he actually collects the data and he goes retrospectively, and then he sees whether the risk can be associated with the disease or outcome. So these are the basic differences. Is it okay?
Yes, ma'am. Thank you, ma'am.
Very nicely.
Thank you. You're welcome.
Okay, so good evening, everyone, and continuing in this series of lectures on the basic research methodology, which is being conducted by the MET division of ABVIMS and Dr. RML Hospital. Today, we will be discussing randomized control trials and a little bit of information on systematic reviews and meta-analysis, but mainly concentrating on the randomized control trials. And to speak on this topic, I have a very eminent person, Dr. Jaya Shankar Kaushik. He is a professor, Department of Pediatrics in PGIMS Rohtak. He is DM Pediatric Neurology, and he is also author of one of the books which he has written just now, and it's just been released. So I think without wasting much time, I should go on to Dr. Jaya Shankar Kaushik. And Dr. Jaya Shankar Kaushik, am I audible?
Yes, Dr. Nitin, thank you.
Okay, so I think Dr. Jaya Shankar Kaushik can start.
Can you enable share screening?
Yeah.
Can you see my slides, Dr. Nitin?
Yes, it's visible.
Okay, I'm audible? Well,
Yes, you are very well audible.
okay. Thank you, Dr. Nitin, and thank you, MET division of RML Hospital. It's a proud privilege that I have been given an opportunity to speak on basic understanding of randomized control trial, and I am very thankful for this opportunity. So I still feel that I am also learning how to conduct our RCT, and every time we keep conducting RCTs and we keep giving RCTs as thesis to the students, we keep learning our own mistakes and we keep improving over a period of the time. So rather I am more of a learner rather than a teacher. So I have tried to assemble what I have gathered till now on randomized control trial. So the main objective of this session will be to provide an overview on the principles, basic principles of RCT, and to understand the methodology of randomized control trial, and to briefly understand the terms called meta-analysis and systematic review. Frankly speaking, I don't want to cover too much or go into depth into meta-analysis and systematic review. The basic purpose will be to understand the basic principles of RCT. The main thing that we need to understand when we are talking about any randomized control trial is, or for that matter, interventional studies or experimental study designs are those study designs where the researcher is going to intervene at some point of the time throughout the entire study. So the first and foremost concept we need to understand is that if the researcher is going to intervene at the study design, then this is an interventional study and not an observational observational study. So the goal of the interventional study is to test the efficacy of a specific treatment or some kind of a preventive measures per se. So the main thing that differentiates an interventional study from an observational study is that the researcher is going to intervene or is going to perform some kind of an intervention so that the outcome or the end point of the study is going to change. So the first question that comes to our mind whenever we encounter any kind of a study design is that, are you going to change the outcome of the study? Yes, if you're going to change the outcome of the study, then this is called as an interventional study. And if you're not going to change the outcome of the study, this is a simple observational study. So broadly speaking, the interventional studies can be divided into multiple ways by which interventional studies can be designed. But one of the most common ways by which we tend to classify is one is called as pre-post design. For example, if you're going to see a parameter called death or the mortality before, and you do an intervention in which you're asking the people to wear a seat belt, and then you're seeing after that intervention, you're going to see that mortality, how much is happening. So that means outcome before an intervention happens and then the outcome after. So this is what is called as a pre-post design. Many people get confused with pre-post design. Remember that it is not the same study participant, right, at the same point of the time that is going to determine the pre-post design. Pre-post design basically means that an intervention is given at the middle of the time. You are measuring the outcome before giving intervention, you are measuring the outcome after giving the intervention. The second very common study design which we generally tend to encounter in interventional studies is quasi-experimental study design. Now, quasi-experimental study designs are usually used when true experiment is not ethical or practical. For example, if there are some conditions in which there is a depression and you want to do some kind of a psychological treatment, your institutional ethical committee says that no, you can't do this kind of interventional study, it does not look ethical. Then you go back and start thinking that yes, few of my consultants give this psychotherapy and few of my consultants do not give this psychotherapy. So that means let me see the outcome of those people who have given that psychotherapy and those people who have not given the psychotherapy. So that means the population is not, very clearly randomized. That means the population in which you are going to do the intervention is not a very homogeneous kind of a population, but still you're able to get a fair idea provided the population which is coming to this consultant and to this consultant is almost nearly the same. So most of the time we tend to use this kind of a quasi-experimental interventional study when it is either not ethical or when it is not practical. So frankly speaking, they are not a kind of randomized control trial or non-randomized control trials because we are not randomizing per se. So the other two important study designs, interventional study designs, are randomized control trials and non-randomized control trial. Now, we commonly use the term called non-randomized control trial when especially the intervention is being compared to no intervention group. So if this is happening, we usually tend to use the term called non-randomized control trial. So broadly speaking, the interventional studies can be divided into pre-post design studies. They can be divided into randomized control trial. They can be non-randomized control trial, or they can be quasi-experimental study designs per se. So let us try to understand with a few examples. Now, for example, if you want to compare ultrasonography and urine pregnancy test to diagnose pregnancy among women with a delay in periods for more than 10 days. So that means women are coming to you with a delayed period for more than 10 days. And now you're wondering which is better, is it ultrasound or is it urine pregnancy test, which is better to diagnose pregnancy? But here you can see that ultrasonography or urine pregnancy is not going to affect the outcome. That means pregnancy, whether it is present or absent, is not going to be determined whether you're going to do ultrasonography or urine pregnancy test. So this is not an interventional study, right? So only if you are intervening Like many of the students tend to understand this thing that, okay, I'm intervening, I'm getting an ultrasound done for this patient, so this is an interventional study. So no, that's not interventional study. Interventional study is something where your outcome has to get affected. So if by that intervention, the outcome, which is pregnancy present or absent, is going to get affected, then only you're going to think of that this is an interventional study. So don't start interpreting RCTs, non-randomized control trial, especially when they're not even interventional studies. So the first rule of the game that we need to all understand is that whether you're going to change the outcome or whether you're not going to change the outcome. If you're going to change the outcome, then this is an interventional study. For example, let me give another example to study the effect of methylprednisolone in COVID-19 associated MISC on mortality. So you know that you are interested in an outcome which is called mortality. The condition or the disease that you're studying is COVID-19 associated MISC condition. The intervention that you're giving is methylprednisolone. So methylprednisolone, whether given or not given, is going to definitely affect the mortality, right? So if that intervention is going to affect the outcome, that is the mortality, then only we call this as an interventional study, right? So it's very important to understand, and first step of the game that we need to understand is that whether it is actually truly an interventional study or not. Many of the time we start going aboard and we start saying that, okay, I'm going to randomize one to give ultrasound, another to do urine pregnancy. They start calling it as randomized control trial. So please, no, right? It has to be first an interventional study. You should be changing the outcome of the study. Then only this is an interventional study. So the next step called randomized or whether non-randomized, everything will come only when you're doing an interventional study, right? So for example, if I'm comparing methylprednisolone and IVIG in MISC on mortality. So again, this is also interventional study, but I'm comparing two groups. That means one group is methylprednisolone, another group is IVIG. So it is possible that I am giving a standard of care to both the treatment groups, and one group is receiving additional methylprednisolone and one group is receiving additional IVIG, and then I'm seeing whether the outcome, that is mortality, is getting affected or whether it is not getting affected. So this is again an interventional study. So I wanted to emphasize this very important concept that if by intervention you are going to change the outcome of that study, right, then only you call it as an interventional study. Otherwise, do not call it as an interventional study. We know that per se, when it comes to randomized control trials, all these randomized control trials are at the highest level of the hierarchical evidence. And we know that case reports, case series, case control, cohort are much below the RCTs. And RCT is one of the most scientifically rigorous method of hypothesis testing. So let us try to now start understanding what do we mean per se by randomized control trial. So the basic structure of randomized control trial is that you have a population of the interest. From that population of the interest, you are going to choose a sample population. So that means you are taking some kind of inclusion criteria, exclusion criteria, and you're choosing some kind of a sample population. And that sample population is a homogeneous population, and you're randomizing them to receive either of treatment A or treatment B. So that means it's an homogeneous population. One group receives treatment A, another group receives treatment B. So that means whether you receive treatment A or treatment B, it is the same population. So the only thing that is different in treatment A and treatment B is that treatment A group receives treatment A, treatment B groups receive treatment B. Otherwise, everything is absolutely the same. And then you go on and observe the outcomes as to what are these outcomes. So that means the two treatment group in a randomized control trial are treated identically except for intervention. That means in one of the group you are getting an intervention, and another group you might or might not receive an intervention. Now the most important thing that also means that if you are choosing a homogeneous population and you are randomizing them into one of the two treatment groups, RCT is going to obviously balance the baseline characteristics that might confound the outcome. Like one treatment group, it just ensures that both the groups are homogeneous, both the groups are almost the same in the baseline characteristic. This you will remember when you see few RCTs, many of the time you will see that the first table of an RCT says that this is baseline comparison and they don't give you p-value. Obviously you're not supposed to give p-value, because a good well-designed RCT itself means that the two groups are homogeneous in the population. So ideally, if the p-value is significantly different between the two groups, obviously you're going wrong somewhere in the methodology. So it's very important to understand that the baseline characteristics are identical in both the treatment groups. So this is an important thing. So what are the steps while we conduct a randomized control trial? So the first step will be that you identify a good research question, arrive at an hypothesis, identify what are the outcome variables. Once a good research question, a hypothesis, and an outcome variable is decided, then you define that what is the target population and how am I going to do the sampling. That means how am I going to choose the population from that target population. How much will I choose? That means how much will be the sample size. How will I randomize this group? Once that the group has been decided, I have to randomize into two groups. And then how do we do allocation concealment? How do we do blinding per se? And then once the outcome is analyzed, how do we do the data analysis per se? Do we use an intention to treat protocol analysis, or do you use a per protocol analysis? That will depend upon what kind of data analysis you are doing. So the basic step, the first step will be to identify a good research question, define the target population, decide how much will be the sample size, then talk about randomization, and then the final analysis. So let us start analyzing each and every step one by one. The most important thing is the focused research question. So let me take an example that if I ask a question that what is the effect of iron supplementation in prevalence of anemia in pregnant women at 32 weeks. So if I ask a question that does iron supplementation, that means the basic thing that I want to know is that if I give iron supplementation to to pregnant women at 32 weeks, how much is going to be the prevalence of anemia? So it is very important to ensure that you are identifying and reframing the research question to identify all the components of population, intervention, outcome, as well as the control group. So it's very important to understand that whenever you're forming a research question, ensure that the population is identified. Here the population is very clear that it is pregnant women aged 25 to 45 years. The intervention is daily iron supplementation, but here I did not mention how much of dose you are giving. So here now I have mentioned that, okay, 100 mg of iron supplementation I am giving. What is the outcome? I want to know prevalence of anemia. So that is the outcome. And at 32 weeks, when compared to control group, that means I also need a control group to know whether if I don't give that iron supplementation, what will happen to the prevalence of anemia? So it's very important to understand that whenever you're forming a research question for a randomized control trial, ensure that all the components of population, intervention, control, and outcome are very, very clearly defined. Once this research question is defined very clearly, then we state an hypothesis. So let me reaffirm that research question is a question. So that means I end it with a question mark. So that means I start with a question called what is the effect of daily iron supplementation, right? But hypothesis is a statement. I say that a daily iron supplementation of 100 milligram between 8 to 28 weeks of gestation to a pregnant woman aged 25 to 45 years will result in reduction of prevalence of anemia at 32 weeks by at least 10% when compared to the control group. So that means I am already making a decision that if there is a group which does not receive iron supplementation, if my interventional group is receiving iron supplementation, the difference in the prevalence of anemia should be at least 10% to state that iron supplementation between 8 to 28 weeks of gestation will be useful. Right. So it's very, very important to understand that hypothesis is a statement. Hypothesis is a statement and it also needs an effect size. effect size means that I am trying to determine that when will I call intervention to be superior to a control group, or for that matter, when will I say treatment A will be superior or treatment A will be not inferior to treatment B, right? So it's very important to understand that the effect size needs to be stated in an hypothesis. Now, the third thing that we need to very clearly define is the outcome variable. One of the very important thing is that primary outcome variable should be very, very clearly defined, especially in your RCTs. What is, for example, in this study, I will say prevalence or frequency of anemia at 32 weeks of gestation. That will be your primary outcome variable. The secondary outcome variables can be, multiple, like, for example, frequency of clinically significant adverse effect. I can say fetal outcome in terms of birth weight. I follow up these patients. I see how these babies are born. So I can, determine the fetal outcome in terms of birth weight. So I can have more number of secondary outcome variables, but primary outcome variable needs to be very, very clearly defined. It should be a very, very objective. It should be a measurable outcome variable. So it's very important to understand that an outcome variable that you are framing should have a quantification. That means it should have some kind of a measurability, like frequency of anemia I can measure. So something which is measurable is a outcome variable. So once our research question, hypothesis and outcome variables are decided, then we start thinking that, okay, which population do I start studying? Choosing the right target population is extremely very important, because this is going to primarily determine the generalizability of the study. What do we mean by target population? Target population is nothing but a population to which it is intended to apply the results. So it's important to frame the inclusion criteria and exclusion criteria. And it is also important to understand broader is the inclusion criteria, better is the homogeneity, right? But take care of the homogeneity, but it is very important that broader is the inclusion criteria, better is the external validity of that particular study. So it's very important to understand that, for example, in this study, if I say that if I want to test for anemia and I choose only those pregnant women who are, eating very well, who are having only vegetarian diet, I am not including non-vegetarian diet, I'm including only those who have a body mass index of so and so, so and so. That means if you make the criteria very stringent, right? So once your results are going to come, I can apply that result only to that narrow population. So it's important to keep the population broad, but don't keep it so broad that anybody who is pregnant, I'm going to enroll, right? So that will also make the things a little heterogeneous, right? So you will have to define very clearly that, okay, I'm going to take somebody who is pregnant between 25 to 45 years, who has been diagnosed with pregnancy test and has at least undergone, an ultrasonography. So you keep some basic criteria so that you're able to apply those results that you're going to come. So remember this, that at the stage of the protocol itself, a lot of mind needs to be applied on how you need to frame the inclusion criteria. So keep it a little broad. Don't keep your inclusion criteria very, very narrow, because once you keep the inclusion criteria very, very narrow, it's quite possible that you will not be able to generalize the results per se. Similarly, ensure that exclusion criteria are also framed in such a manner that you don't miss a major chunk, but yes, important confounding variables you are going to take care to exclude, right? So how you are going to choose from that target population, right, among everybody who is coming, is what is called as the sampling technique. So the sampling technique, that means you have a full population that is pregnant women, and from that pregnant women, how are you going to choose those pregnant women is what is called as a sampling technique. And one of the most common sampling technique which usually the clinician uses is a consecutive recruitment. It is better to avoid convenience or judgmental sampling. Convenience sampling means that, okay, my OPD days are on Monday and Wednesday, I am going to take only on my OPD days, I am not going to take on the other OPD days. It is quite possible that, all high risk pregnancies are coming on the other days, and nobody is coming to you. So it's very, very important that don't choose a convenience sampling, that anybody who comes to me in my OPD days, I will recruit. That's not the way to recruit it. You define an inclusion criteria, talk to other consultants of the unit, ensure that, you know, you're putting the inclusion criteria to every consultant that, yes, if the person is fulfilling these inclusion and exclusion criteria, please give me a call. I will come and recruit these patients. So do not choose convenience sampling, and this is one of the biggest errors that usually happen, and this is one of the reason why many of the, you know, journals tend to reject your RCTs per se. So these are some of the points that you need to take care at the planning stage itself. Now, the next thing that comes is the sample size. And remember, a very, very important thing is that the sample size calculations are always based on the primary outcome variable, which could be a dichotomous variable or it could be a continuous variable. For instance, prevalence of anemia is, you know, prevalence of anemia is a kind of a variable which is, you know, dichotomous. Continuous variable is like, you know, weight of the baby that has been born is a continuous variable. So remember that you can have any kind of a primary outcome. You can have continuous variables, you can have a dichotomous variable, but it is important to understand that sample size calculations are usually based on the primary outcome variable. So even if you're having multiple secondary outcome variable, it is the primary outcome variable that determines what is the sample size. The next question that comes to everybody's mind is that who decides which is the primary outcome and which is the secondary outcome? It is you who decides what is the prime. So according to you, if as a researcher, I feel that the main purpose is to prevent mortality, right? So my primary outcome will be mortality. But if I am being a pediatrician, if I am involved in this study, I might not be interested in maternal mortality. I might be interested in what is the birth weight of the baby, right? So primary outcome will be determined by the person or by the researcher who is involved in the study. So nobody usually determines who is going to decide which will be the primary outcome variable. But yes, primary outcome variables should be something which is you know, very clinically very important, clinically very relevant. Choose your primary outcome variable very carefully because your sample size calculations are usually based on that. Similarly, I also told you that effect size, that is accepted clinical difference between the two therapies. That means group A and group B that a researcher wants to observe in the study. For example, in this study, I told that if I give iron supplementation, right? If I give iron supplementation to one group and I do not give iron supplementation to another group, I will consider the prevalence of anemia to be significant only when there is a difference of more than 10%. That means at the end of the study, I say that, you know, the prevalence of anemia in the iron supplementation group was 9%, and somebody who did not receive iron supplementation was 7%. I will have to say that, sorry, this is the difference between 9 and 7 is only 2%, which is definitely less than the 10% that I have committed. So it's very important to understand that what is the effect size is predetermined before. That means as a researcher, you're already thinking as to what should be the effect size to call it as a significant thing, right? So similarly, type 1, and most of the time you will realize that effect size is kept as 10% difference. But yes, it will depend upon what kind of clinical difference that you want to consider it as clinically different. For instance, if I am dealing with some kind of a rare condition which has a very high mortality. If mortality is going to be reduced even by 2%, I might consider this to be an important. So I can keep my effect size as 2% also. So it entirely depends upon the clinician and the researcher to decide which will be the effect size. Similarly, what will be the type 1 error? Usually type 1 error is set at 5%, and power of the study can vary from 80% to 90%, but most of the time you will realize the power is usually set at 80%. But obviously, if you increase the power, the sample size will automatically increase. The next thing that comes to the mind is what is the type of the comparison. If you had noticed, I have used a word called superiority, non-inferiority, or an equivalence trial. So the only thing that we need to understand is that most of the time the superiority trials are placebo controlled trial. That means, is it better than not giving treatment at all. For example, as I told you in the depression case, that I might give you a standard of the care, but I might additionally give some kind of a psychotherapy, which I think that if I don't give any therapy, this might be better, right? So remember that superiority trials have a question, which is it better? In which experimental treatment is usually superior to the placebo. Similarly, equivalence trials usually state that is it similar enough? That means the experimental treatment is equivalent to the active control. So it is neither worse nor it is better than the control by greater than a margin. That means I'm defining a margin to define that it is not worse than this, nor it is better than that. Similarly, non-inferiority trials are that is it unacceptably worse? This is usually a non-inferiority trials. You will realize that most of the time that we are doing on new drugs are most of the time non-inferiority trial, in which the experimental treatment is not inferior to the active control, that is the standard of the care. But remember that non-inferiority trials are not very, very good to independently show the efficacy, right? Which is much, much better elicited by an equivalent study or by a superiority trial. Now, once you have decided that, okay, what is the research question, what is the target population, and you have decided what will be your, type of the study design, the next important thing is the process of informed consent. Remember that a written informed consent and rather video consent is something which is required. And in the video consent, many of the time I have seen students, saying that, okay, I'm going to do this study. Are you interested? Are you not interested? So you can't ask such type of question on a video consent. And many of the time written informed consent is like, you give a paper to the patient and say, sign it here, sign it here, sign it here, tick, tick, put tick here, I will sign, come, you also sign here. So please ensure that don't do this kind of written informed consent. You should ideally provide a consent, tell that it is in research, we are not very sure. What is the purpose of that research? There are certain potential benefits. There might be some risk that can be associated. What will happen if somebody develops some kind of an adverse effect? And it is a voluntary participation. If you say that, no, I don't want to participate, I am not going to stop your treatment, you're most welcome to say bye-bye and go at any point of time. You can withdraw at any particular stage. Even after giving treatment, you feel that, oh, this is not my cup of tea, you can walk out. I won't trouble you, I will continue my treatment, I won't harm you. This is very important to ensure that during your video consent, you're covering all these components. Routine care will not be affected by refusal to consent. This is a very, very important thing that, oh, now you're not refusing me to consent. Let me see, show to some other better doctor. So no, don't avoid this kind of keeping grudges with you. It is a kind of a research. Ensure that some amount of sanctity is maintained. Ensure that you're taking a video of the consent process that is there. It should be archived. You should always keep a record of it. Now, once you have decided target population is done, the next step that comes is randomization. Now, many of the students get confused that what is randomization, what is allocation. So just to remember that randomization basically refers to a process of assigning the study participant to experimental group or the control group at a random, such that each participant has an equal probability of being assigned to any group, right? So that means randomization per se is going to ensure that it is going to eliminate the selection bias. It is going to balance all the known and unknown confounders. And at the same time, if you can also do a non-random kind of thing in which odd registrations, even registration, alternate people can be given one treatment A, another treatment B, another treatment A, another treatment B. So all these things are non-randomized method. So randomization per se, please understand, is a method or the process by which you're assigning the study participant that if a first participant is going to come, which treatment I'm going to give. If the third participant is going to come, which treatment will I give? So that means randomization is done even before the first patient is recruited, right? So that means I am creating a list of entities in which person is going to receive which treatment is already decided from 1st to 60. Suppose my sample size is 60. So from the first patient to the 60th patient, I already decide that who is going to receive treatment A, who is going to receive the treatment B. Now, how do we do randomization? There are multiple methods of doing randomization. One of the simple ways using random number table, but we generally at this point of era, we usually use a website like randomization.com. There are multiple websites which can help you, but one of the very user friendly website which I have seen is randomization.com. But yes, simple randomizations are very, very useful, but very small clinical trials, if you're going to do a very large clinical trial, then simple randomization is good. But if you're doing very small trial as a part of your thesis of your student, or for that matter, if you're doing a very small RCT on a small group of patients, it's better to use something like block randomization and stratified randomization. Now, what do we per se mean by block randomization? Now, block randomization is that, suppose you see this example, that means either treatment A or treatment B. So if I already decide that I have a block of 4, that means in my mind, I already know that once an A patient has come, the second patient is also A, the third patient is B. So even before the fourth patient comes, I already know that the fourth patient is a treatment B, right? If I'm biased towards treatment A, I might say to that treatment B fourth patient that, oh, please go home. You go, you are not the right person to come. So another very, very thin patient comes, then you think that, this can be given B. So come, you are the fourth patient. So that means you have introduced your own bias. That means with this kind of fixed kind of block randomization, you already know in your mind that if somebody has received A, B, B, that means block randomization means that at the end of 4, I know that equal number of A and equal number of B will be received, right? This is good, but this also has some kind of flaw. So what we use is what is called as a variable block randomization. So in variable block randomization, I don't know whether the block is of 2 or whether the block is of 4. So that means once the first patient is A, the second patient is B, the third patient is A, I cannot be very sure that it will be only B, because I don't know what will be the block size of the next patient. So it can be, this is what is called variable size block randomization. And we generally, in most of our thesis, we generally tend to use this kind of block randomization. So if you visit randomization.com, it's a very, very simple thing. You can just write a drug A and drug B. You know that number of subjects that are required per block will be 2 and you need 10 blocks. So you can write the number of subjects per block, number of blocks. So that means you have chosen the variable sized block. So that means one block could be of 2, another block could be of 4, another block could be of 6. You know that the sample size total is 60, right? So that means 6 into 5 will be 30, 4 into 5 will be 20. So this completes my sample size of, this is the, 30, this is 20, so 50 is done, this is 20, so this is 70. So that means if my sample size is 70, I will automatically assign how many subjects will be given per block. So this is what is called as variable size block randomization. This can be very easily done using randomization.com. And once you generate and click on that button, this is the kind of the list that will be provided, that from first patient to the 70 patient, it is already known that who will receive drug A and drug B, right? So if I am the study person, I will not do it myself, right? So if I do it myself, what I know is that, okay, I know that the first patient will receive treatment B, second is treatment A. So that means already I am biased that I know that so and so plan will come, right? So it is better that this randomization is done by your friend who is not involved in the study per se. The other type of this is what is basically variable size random block randomization, which we very commonly use. The second type of randomization is stratified random sampling, which many people use, especially, one of the way to stratify is gender, like, 70 males, 30 females. Out of 70, ensure that, all males are equally divided. So I want, this will be a kind of study design in which stratified sample size, I want to be very, very sure that, males and females are equally represented. I don't want at the end of the study to say that, okay, 70 are male and 35 are female. So this drug is going to work only in males and not in the female. So if you feel as a part of your study, you think that there is some kind of a variable which is going to confound majorly, you can use a stratified randomization also. Now, how do we randomize? How do we do per se? There are two major type of study designs that we tend to use. One is called as the parallel study design, in which the study participants are randomly assigned to either of drug A or drug B, and at the end of intervention, you're studying the outcome in drug A and outcome in the drug B. The other study design which we generally tend to use is crossover study designs, in which a person, that's a homogeneous study population, is divided into drug A, and suppose you're doing a placebo kind of a study. So at the end of your intervention, especially if the drug or the intervention is of a rapid onset and a short duration, you might have to give a washout period before you cross over. That means you're giving the placebo to that person, you're measuring the outcome at the end of drug A, at the end of this means. So that means outcome in a parallel study design was only once, whereas in a crossover study design, you're going to study the outcome at two intervals. That means one after the drug A was given, another after placebo. Similarly, one after the placebo was given, another was after the drug A was given. So this was all about randomization. So the students should be really very clear that randomization is done even before you're recruiting the first patient. So that means at the protocol stage itself, if the randomization plan is attached, then we know that, okay, this is a very good plan which is there. Now, what do you mean by allocation concealment? Now, allocation concealment is the purpose of allocation concealment means that it will prevent a selection bias. It will protect an assignment sequence before and until the allocation is done. So that means if a patient X is randomized to treatment group A, this allocation concealment will ensure that he or she gets only treatment A and not treatment B, right? So that means that if allocation concealment means that if a patient number 3 has come and by my randomization list, the 3 was supposed to receive drug B, so the 3 should definitely receive drug B, and I should not be interfering by saying that please go, tomorrow come, and by that time I take another patient. So this allocation concealment is preventing this kind of a bias from the researcher, right? So one of the two common methods that we tend to use for allocation concealment is what is called sealed envelope technique. Another is distant randomization. Distance randomization means that somebody who is sitting in the telephone, a researcher who is abroad, or for that matter, somebody away from your institution is telling you that, okay, your third patient has come. Okay, now the third patient should receive drug B. So then accordingly, you give drug B. So that's distance randomization. But we generally tend to use sealed envelope technique, in which sequentially numbered opaque sealed envelopes are usually used. Ensure that you're using opaque envelope so that you're not, looking into the light and you're able to make out, oh, this is treatment B. Let me keep it. Let me send this patient away. Let some other patient come so that I give treatment. So this is not something intentional. What I didn't mean to say that, it is intentional, but many of the time as a researcher, you're biased. That means suppose you're trying a new treatment, you're biased that, oh, this new treatment is going to be definitely better than the standard treatment. So that means there is some kind of bias that the researcher might have. So you need to ensure that allocation concealment is done really very, very clearly, right? So it's very, very important to ensure that sealed envelope techniques are used. Use an opaque envelope. The assignments can be placed in advance in a set of envelope by someone, not the researcher. So that means that you're choosing an envelope. That means the randomization list was available. So I give this randomization list, which was generated by, suppose if I am the researcher, I ask my friend X to prepare this randomization list, and I tell this X friend to make 60 envelope, label this envelope 1, 2, 3, 4, 5, 6, 70 up to 60, 1 receives drug B, drug 2 receives drug A, 3 receives drug B. So that means within that envelope, I put a slip that says drug A or drug B or drug B, and then I seal it, right? So that means once the third patient is going to come, I will open this third envelope and I will see that, okay, this third envelope has treatment B. So this third patient has to receive treatment B. So this is what is meant primarily by allocation concealment. And this is a common method that we tend to use, which is called as the sealed envelope technique. The third method, third term, which is a little confusing when it comes to RCT, is what is called blinding. Blinding basically refers to the practice of, preventing the study participants, the investigator, and the statistician from knowing who is in the experimental group, who is in the control group, in order to avoid them being influenced by such a kind of a knowledge, right? Single blinded means that the study participant who is getting enrolled into the study does not know whether he is going to receive treatment A or treatment B. If the study participant as well as the researcher does not know whether he is receiving treatment A or treatment B, these are called as double blinded study. But even if the statistician also till the end does not come to know, he just tells that treatment A is superior to treatment B, but he doesn't know which is treatment A, which is treatment B. This is what is called triple blinded study. But yes, many of the time, all the three are aware. This is what is called open labeled study. Many of the times you tend to use what is called as open labeled study. Suppose you're comparing, a medical treatment from a surgical treatment. How is it possible that even the study participant doesn't know whether I'm eating the medicine or whether I'm going to go to surgery, right? So such kind of comparative studies are usually open labeled. For instance, you're comparing a tablet and a syrup formulation. You can't do a, blinded kind of a study, right? So it's very important to understand that there are certain situations in which blinding cannot be done. Right. So in such a cases, you tend to use open labeled kind of a study design. Now, it's very, very important. Another very important thing that I wanted to highlight is that the procedure must be spelled out very, very clearly. So that means standard operating procedures should be very clearly framed. You will have to very clearly define how will the treatment drug A and drug B will be administered to study participant. How are you going to train the party? How are you going to train the researcher? How are you going to ensure that certification is given? A proper checklist is being made. How do you ensure that the person who is, as researcher or for that matter, a person who is doing the study is very qualified to perform this kind of study? Has they been trained how to do randomization, how to do? So everything has to be very, very clearly told in your protocol stage itself, that as to how you are going to do it. So standard operating procedure, that means once a patient comes, will the patient be first administered to your RCT, or what will you do first, right? So that means after reading your protocol, if more questions come, that means your standard operating procedures are not clear. So please ensure that you show your protocol to your friend. And it is always good to show it to your enemy, so that he, criticizes that protocol, right and left, and say, this is also not done, this is also not done, this is also. So pick up all those things and improve your protocol. Ensure that, every component of your, protocol is very, very clearly spelled out. This is a very, very important point, because if the standard operating procedure as to how you're going to handle the patient is not clearly spelled out, your RCT is going to get rejected, right? So it's very important to very clearly spell out how you're going to do, because this is going to majorly influence your internal validity of the study. As I told you, the inclusion criteria are going to determine your external validity. Your methodology, robust methodology, is going to influence your internal validity. So it's very, very important to understand that you follow a very kind of a strict procedure. Now, 2 or 3 important things in view of RCT that everybody should be aware is that Ctri registry is mandatory for all clinical trials that are conducted in India. In 2004, ICMGE, that is International Committee of Medical Journals, have very clearly told that if you have not registered, I am not going to publish your study. So if your trial is not registered, then please don't expect that it will be published in any of the ICMG recognized journals. So it's very important. Ensure that a proper institutional ethical committee clearance is very mandatory. Ctri registration does not happen without institutional ethical clearance. So the first step is always institutional ethical clearance. Ensure that if you're doing an interventional study, a data safety monitoring board should be committed. Do not keep yourself into that data safety board monitoring. Keep 2 or 3 of your colleagues, spell out that so and so person is going to ensure that that all the patients are safe. Create a data safety monitoring board, especially in all the interventional studies. And I just wanted to highlight that Ctri from last 1 or 2 years have made it mandatory that you have to prospectively register. So if they say that, okay, I have conducted the study, please register my trial, they will say, sorry, you have to look for somebody else. Ctri now says that at the protocol stage, you will have to spell it out very clearly that, okay, I am doing this study, so that whole world knows that, yes, you are doing this study. You are keeping these as your inclusion criteria, these as your exclusion criteria. You are keeping these as your outcome measures. So it's very important to ensure that Ctri registration is done. Ctri is a very professional organization, and you will realize that the registration is very fast, and I have had a very good experience with Ctri registration in all the RCTs that till now I have conducted. So Ctri is a very professional organization, so ensure that once your ethical committee is clearance is done, Ctri should be registered. So it's also important to understand that if you're doing a new drug, or if you're doing an old drug for a new indication, or an old drug by a new route of administration, you will require a DCGI approval. Rather, this dictum is usually told by your institutional ethical committee itself. The institutional ethical committee says that, sorry, I cannot give you the ethical clearance. You will have to go to DCGI, take an approval because it's a new drug. Once DCGI approves, come back to me with that DCGI approval letter, then I will think about it. So ideally, IEC clearance should not be given to a trial which is, involving, new drugs, or an old drug for a new indication, or an old drug by a new route of administration. So ensure that, DCGI, it is ultimately, let me tell you, it is ultimately the researcher's liability. So you have to be really very careful when you're doing it. Now, when it comes to handling the data, this is one of the loose area for most of us, that, once the study is done, once, the thesis is completed or the research is completed, you're throwing out all the data. Oh, this paper is published. Now I don't want to keep any case record. So ensure that case record forms are kept safe. Ideally, people say that it should be kept for at least 5 years after the publication date that has been there. Generally, people also say that more than 20% of follow-up losses are very unacceptable. So don't expect that, once the follow-up loss is up to 30%, somebody is going to say, oh, please welcome, your study is very robust. They might probably just reject the study design. You might have to state this as a limitation. Ensure that whenever a data entry is done, 2 investigators in separate Excel sheet is doing it, not that, you're asking your student to just record everything and it's done, right? So just ensure that 2 investigators in separate Excel sheet are doing it. Compare those Excel sheets, that data entry problems are not happening. Ensure that the treatment effect, this is a very important concept that I'm trying to tell you, is the treatment effect. That means once your results are out, right? That means once your results are out, I want to now say whether treatment A is better or whether treatment B is better. There are 2 ways to say it, right? If I state that how likely is it that the result obtained is due to a chance alone, Then you use what is called p-value, confidence interval, right? But most of the RCTs which are done on a small sample size are more interested in knowing how big is the treatment effect. So they are interested in odds ratio. They are interested in, relative risk, or rather relative risk reduction. So if I just mention the p-value, the journal will send it back to you stating that what is the magnitude of the treatment effect. So please ensure that you commit on magnitude of the treatment effect apart from significance of the treatment effect alone. So it is many times important to ensure that magnitude of the treatment effect is also handled along with your significance. So many of the time just that treatment A is superior to treatment B because the p-value is less than 0.05. Sorry, they say that tell me how superior is treatment A as compared to treatment B. What is the relative risk of giving treatment A versus treatment B? So most of the journals are now interested in magnitude of the treatment effect rather than the significance of the treatment effect. The other thing that I wanted to also highlight is the basic difference between intention to treat analysis and per protocol analysis. Now, when it comes to intention to treat analysis, intention to treat per se means that it ensures that all patients allotted to either of the treatment group or the control group are analyzed together as representing that treatment arm, whether they received it or whether they did not receive it, whether they completed the study, whether they did not completed the study. So that means if I recruit 50 patients for iron supplementation, 50 for control group, my denominator, suppose I see that the prevalence of anemia is, anemia. I say that, okay, 12 of them who received iron supplementation were anemic and those who did not receive were 10. If my denominator is 50, that means 24% and 20%, this is what is called intention to treat. It is possible that those who received iron supplementation, 11 of them ran away, right? And in the control group, 5 of them only ran away. So when you look at this data, that means 12 to 39, this is 30.7%, which is definitely much, much better than control group. This is what is called as per protocol analysis, in which only those who have completed the study are included in the denominator, right? Most of the people, most of the journals prefer intention to treat analysis, because if 11 people have run away from iron supplementation, right, in this treatment group, I know that those 11 people who have run away because it did not improve, rather they developed some severe side effect, right? So most of the journals do not accept per protocol analysis and they prefer intention to treat analysis. So intention to treat per se means that I intended to treat that patient, whether he continues that treatment or whether he runs away from that treatment. I will consider him to have received that treatment, right? So this is what is basically meaning of intention to treat analysis. But yes, many journals do ask you to report both intention to treat as well as per protocol analysis, especially when the follow-up losses are very, very minimal. But when the follow-up losses are very, very large, they never will usually accept a per protocol analysis. Now the last part is that once you are completed with your RCT, you have to appraise your RCT. So appraising RCT is to ensure that the validity of the trial methodology, ensure that the research question is focused, randomization plan, what randomization you're going to use is very clearly stated, how you're going to do allocation concealment, that's very clearly stated. The protocol clearly tells you the standard operating procedure. You have also clearly stated whether I'm going to do blinding or not. How am I going to handle the analysis? Right? Am I going to do intention to treat analysis or am I going to use per protocol analysis? What is the sample size? So that means still your protocol is valid with all these things. Then we usually do not accept this to be a robust thing. So validity of trial methodology is very, very important. So similarly, magnitude and the precision of the treatment effect. So it's also important to understand, as I just told you, that it is not only the statistical p-value. So don't run behind that p-value of less than 0.05 as some magic number, right? So rather, if the treatment effect size is much bigger, even if the p-value is not significant, it might meet some kind of clinical significance. So I'm trying to re-emphasize the fact that it is, magnitude of the treatment effect that is far more important than just the statistical significance. And the last thing that we also look at is applicability of the result to your patient or to the population, which will be determined by your external validity. And you can very clearly make out from this presentation that is garbage in, garbage out. You don't prepare a good protocol, your study is not going to get published in a good study, in a good journal. So it's very important to have a very, very robust methodology. You have to ensure that all steps are done at RCT. So 90% of your effort has to go at the protocol stage rather than at a later stage. We generally appraise the randomized control trial using a consort study, a consort statement. We have a checklist. So once the manuscript is prepared, the manuscript is usually checked with whether they have mentioned all these items or not: sample size, how sequence was generated, how was implemented, how blinding was done, whether they have written a study flows design or not, how was the numbers that were analyzed, what were the adverse effect, how did they discuss. So all these things are basically a consort.
Dr. Shankar, your audio is not, your voice is not audible. I think there is some problem.
No, can you hear me?
Yeah, now it's.
Oh, I think. Since when did you not hear me?
Just 1 or 2 seconds.
Okay, thank you. So just to ensure, all that I just mentioned was that consort statement is very, very important to be used, and you often tend to use a study flow to ensure that study flow is being depicted as to how you randomized, how many allocation, how many followed up, and how many ultimately landed up in analysis. So this is a kind of study flow which is usually given in the study design. Now, with this we reach to an end of RCT. Just 1 or 2 slides on what is systematic review and meta-analysis. I'm probably not the very great expert to make you understand systematic review or meta-analysis, but systematic review is nothing but it is an objective method of finding an answer to the research question. Once many people have conducted RCTs, right? So you are always wondering which one will be, how do we decide whether this treatment A should be given or treatment B should be given? So one of the objective way to find answer to such kind of research question is what is called as a systematic review. So systematic review basically systematically identifies, right? Selects, that means it selects the RCTs, it evaluates whether this is good, not good, synthesize all the data, right? So it systematically identifies, selects, evaluate, and synthesize all high quality research evidence. And it is nothing but it is just an exhaustive summary on the research question. Most of the time, the panel of experts do an systematic review. They not only look at published data, they also look at unpublished data, including those which are, at the levels of just abstracts, conference proceeding. So they also try to contact those authors and try to find out the data from them also. So when it comes to meta-analysis is just that once we have pooled in the data from multiple studies, the meta-analysis is a statistical method to pool the estimates from 2 or more studies. So meta-analysis is a statistical method by which you are telling that treatment A is better than treatment B by what effect, right? Whether treatment A and treatment B, which is better, we do generally in RCT. If you want to quantify, if you want to tell by a statistical method as to what is the estimate, right? Tell me how big is the treatment A as compared to treatment B, then we pool statistically, this is what is called meta-analysis. So that means all systematic reviews per se will have meta-analysis, but meta-analysis, not all statistical reviews per se will have meta-analysis, because it is quite possible that you pulled in many RCTs and you did not get too much of a data to do, meta-analysis. But usually if you're doing a meta-analysis is usually a part of systematic reviews only per se. So the steps that we generally tend to use in systematic review is that you formulate a research question, you decide that I'm going to choose the study designs, choose those studies where this is the participant, they have done this intervention, this is the comparative group, this is the outcome that they have seeken. So you make a protocol, you register your systematic review, define your inclusion and exclusion criteria. That means I will choose those studies which have these and these. I will exclude those studies which do not mention so and so, so and so. Similarly, do a literature search and do the study selection. Look at the quality of the evidence, extract the data, analyze the data, do a meta-analysis, and then generate the level of evidence. And then the results are usually presented in a systematic review. So meta-analysis is nothing but it is an objective and a valid method of analyzing and combining those results. So it has a very good diagnostic and therapeutic value, which is usually used for what is called evidence-based treatment. Many of the times you would have, realized that, what is the evidence that, treatment A is better than treatment B? Such kind of answers are usually generated from meta-analysis. So, but yes, conclusions provided are far more statistically stronger than the result of a single study. And we can see that above RCT, you have systematic reviews and meta-analysis. So at the level of hierarchy, the systematic reviews and meta-analysis of systematic reviews of RCTs are at a much higher level. So with this, I almost come to the end of this presentation to summarize that a well-designed, methodologically sound RCT evaluating an intervention provides a strong evidence of cause-effect relation. Ctri registration, please remember, DCGI ethical approvals are mandatory. Hope at the end of this presentation, at least students who are listening, who are youngsters are listening, should be clear on what is randomization, what is allocation concealment, and what is blinding. And we often tend to use consort statement and checklist while we are reporting an RCT. Hope I have provided some amount of justice, if not too much, to the objectives that I started with. Thank you very much. And I thank once again Dr. Nitin and the MET division of RML Institute for providing this opportunity. Thank you.
Oh, thank you, Dr. Shankar. I think in whatever lectures I have ever heard on RCT, this is one of the best. Absolutely simple. And all the terms which we often come across as faculty, or if graduates who are doing their studies, they come across, I think all the terms have been explained beautifully. So just one or two questions I have for you, Dr. Kaushik, is that this trial registry is a must now. The trial registry is a must now. Now, there is a problem which we face because in most of the theses, especially in certain departments, they compare one procedure to the other, especially when they are giving thesis topics to their postgraduate students. Now, often when they come to the institutional review board or to the ethics committee, they often give this, justification that no, these two procedures are very well done in literature. It is just that we are trying to compare the two. So this does not become a randomized control trial. And most of the times, I have seen in certain IRBs and ethical committees, this is being passed as a randomized controlled study, not a trial. So firstly, that I think this should be called a trial, because though there are two different methods which are being used, though they might be existing in literature, because most of the time researchers say, no, this is not new. That is why it is not a trial. It should be called a study. So is this a valid justification which they give, or is it not a valid justification?
Yes, thank you for this interesting question, Nitin. But what I wanted to, that's why I started my presentation from the first thing by stating that what is an interventional study, right? Many of the people consider diagnostic accuracy studies. That means where you are comparing two investigations for establishing a diagnosis to be a randomized control trial. So first step is whether this study is an interventional study or not. Right. So if the intervention, that means suppose they are comparing two, diagnostic method, if that's not going to change the outcome of the study, this is not an interventional study. So please do not use terms like RCT, quasi random. So first step is whether it is interventional study or not. So you need to identify that only because you have one intervention, another comparator does not mean that it is an, RCT. If you're comparing treatment A, diagnostic 1 from diagnostic 2 does not mean that it is an RCT. So the only thing that I wanted to emphasize as a simple rule is that if your intervention is going to change the outcome, then only call it as an interventional study. Otherwise, don't even call it as interventional study. And this is the reason why I started my presentation by stating that don't label diagnostic accuracy studies as RCTs. If you're not changing the outcome of the patient, do not call them as randomized controlled trials.
Now, suppose if there are two surgical procedures which are being done, surgical procedure A or surgical procedure B. Now, both these procedures are very well there in the literature. Some work has been done on procedure A also and procedure B also. Now, a researcher wants to compare the two procedures. And the researcher says that, okay, I want to do this. I want to compare both of them. And I want to see the effect, like suppose, okay, maybe it is that time to heal or maybe any other outcome which they decide. So does this become a randomized controlled study or a trial?
Okay, now let me thank you. I understood your question. So the basic thing is that if the population is homogeneous, that means if they are choosing one homogeneous population, suppose they say that I'm going to, choose some elderly patients who are presenting. I'm just giving an example. I'm not a surgeon, so I might give a very lame example. But I'm just trying to say that you are taking an old person and you are, having a mass in the abdomen, and I want to know, or for that matter, you say that appendicitis patient has come to me. All patients are there. If a homogeneous population is coming and then you are randomly dividing them into one of the true surgical treatment, then this will be definitely an interventional study, right? So especially the outcome is going to change from your intervention, whether you're going to do surgical procedure A or surgical procedure B. The next question that comes is that should I give ethical clearance or not? It is totally up to the domain of the ethical committee people, whether they consider this as a good study or not, right? Suppose if the generally speaking, if you are doing procedure 1 and procedure 2, and procedure 2 is a standard of care and it has produced very good results, then why do you need to compare this with a standard of care which is already providing a good study result? So many of the ethical committee people say that if standard of care is itself working so well, why are you doing a study on comparing another surgical procedure? So it entirely depends upon what is already known in the literature. So it is the author who has to give that justification, or the researcher who has to give that justification.
So unless and until they are randomizing, we cannot call it as a randomized control study or a trial. So if they are just comparing one procedure with the other, they have not randomized the patient. It was the surgeon's prerogative that, okay, this is group A. I am treating this X person with plan A and this Y person with plan B. Then it is not a RCT. Then it is just a comparative study which they are doing.
No. It is still an interventional study, right? So you can call them as quasi-experimental studies.
Exactly.
Right. So you need not call it as a randomized control trial,
So
because you did not create. Yeah, you did not create a randomization list, right? You did not create a randomization list at the initial stage that the second patient of appendicitis will go only this will undergo this procedure only. So if you have not done this procedure, this is not RCT. Many of the time you will realize that most of the surgeons, they generally tend to do quasi-experimental study designs.
Exactly. And
Right. So it's not a bad study. It's not a bad study because
but does quasi-experimental need to be registered with Ctri?
The answer is very simple. Yes.
Okay. So even that
right. Ideally speaking, any interventional studies has to be registered. Right. So it is always better to be registered than not registered, because if you have not registered, you have lost the opportunity. Tomorrow the journal says that no, this is not a quasi experimental. You have done a very good study. I am interested in publishing. Please tell me the registration ID. You can't go back to find out registration ID. Ctri will say that please, sorry, bye. You can't do anything about it now. So it's always better to register than not to register.
Okay.
At times Ctri people who are sitting are very, very good. They can take a decision that, okay, you need not register on this, but make an attempt and register.
Exactly. And one last question is that data safety monitoring board. So how do you form it? You said you can take 3 friends or they can form a data safety monitoring board, but are there any other guidelines for forming a Dsmb? Or it is up to the prerogative of the investigator that he decides how to form a data safety monitoring board?
Not at all. It should never be a prerogative of investigator. Then in that case, if I am doing, I will call my 2-3 friends and then they will say that, okay, this will be data safety board. So that's not data safety board. So it is the ethical committee's prerogative to decide who will be the data safety board members. Right. So most of the time you will realize that data safety board member, one of them is from your own specialty. You can't do an data safety board of an obstetric person. If an obstetric trial is happening as a pediatrician, I might not be, able to understand anything. So most of the time you will realize that institutional ethical committee appoints somebody from obs gynae. Whether he is a friend or enemy, that I don't know. But it is not the investigator who does it. Right.
It has to be by the ethical committee.
Correct.
So with this, I thank Dr. Jaya Shankar Kaushik for a wonderful talk he has given on randomized controlled trials. And I think he has simplified it just the way he has simplified pediatric neurology in his book, Clinical Approach to Pediatric Neurology for Postgraduate Students and Practicing Pediatricians. So thank you, Dr. Jaya Shankar Kaushik, for a wonderful talk.
Thank you so much, Dr. Nitin, and thank you, RML Institute. Thank you so much.
Thank you.
Thank you. Bye.